Hi, I'm Dr. Tom Buchholz. I'm a radiation oncologist and I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, California. I welcome you to our discussion of breast cancer cases today. We really have an outstanding multidisciplinary panel, including breast surgical oncology, breast medical oncology, breast radiation oncology, and breast imaging or breast radiology. And I'd like each of our panelists to please introduce ourselves. Let's start with Dr. Mucinous, our breast surgical oncologist.
This is Terry Mamnes. As Tom mentioned, I'm a breast surgical oncologist, and I'm the director of the Comprehensive Breast Program at the Orlando Health Cancer Institute in Orlando, Florida.
Thank you, Dr. Mucinous. Dr. O'Shaughnessy.
Hello, everyone. I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center and the Chair of Breast Cancer Research in the U.S. Oncology Clinical Trials Network in Dallas, Texas.
Thank you, Dr. O'Shaughnessy. Dr. Shaw.
Hello, I'm Chirag Shah. I'm a radiation oncologist at the Cleveland Clinic and serve as the Director of Breast Radiation Oncology and the Director of Clinical Research.
And the final member of our panel is Dr. Butler.
Hello, everyone. I'm Dr. Rennie Butler. I am Associate Professor at Yale University School of Medicine and Diagnostic Radiology, and I specialize in breast imaging.
Thank you, Dr. Butler. Our next case is a 48-year-old postmenopausal female with stage 4 breast cancer. Her disease is ER/PR positive, HER2/neu negative. She has a left mucinous carcinoma of the breast, now with recurrence 5 years after her local regional treatment, which consisted of lumpectomy. She's been on tamoxifen. She has metastasis to the lung only, and she's currently on Palbociclib and Fulvestrant. And the question is, if the disease progresses, what would be the recommended next line of treatment? So a little bit about her presentation. Currently, her positive pertinent symptoms were a palpable mass found at the original diagnosis. She's currently asymptomatic with an excellent performance status. Again, despite outside of her medical history, she's a relatively healthy person. So she was found to have a metastasis in December just of 2020 with an enlarging pulmonary metastasis, prominent mediastinal and right hilar lymphadenopathy. Her history dates back to 2013 when she first was treated with a left breast cancer, a T1N0. She underwent excision with negative margins. Her pathology from 2013 was a mucinous carcinoma. It was ER positive, PR positive. When she presented with her original diagnosis of metastatic disease 5 years later, she underwent a lung biopsy showing a well-differentiated mucinous carcinoma consistent with her breast primary, again, ER/PR positive, HER2 negative, and histologically consistent with her original diagnosis. She's undergone genetic testing back in 2013. She had an Oncotype DX score was low in 2013. So it's an unusual presentation of metastasis despite this. In 2018, she was found to have a rising 2729, which prompted the evaluation and the detection of her lung metastases. And so now, after 2 years of being treated, she's having an enlarging metastasis, which will be shown here. But first, we thought we'd benefit from some discussion about ultrasound and MR imaging of mucinous carcinomas, and I'll turn it over to Dr. Butler.
From an imaging perspective, it's again important to remember that some cancers present with circumscribed or nearly circumscribed masses, and sometimes those masses even mimic cyst. So it's incumbent upon us to pay very close attention to margins and to interrogate these masses with color Doppler evaluation to determine whether or not there is vascular flow that would support a solid mass rather than a cyst. On an MRI, mucinous carcinoma has the unique feature that it has bright T2 signal. Most breast cancers that we see on MRI have low or intermediate signal intensity on T2, but this image on the far right of the slide shows a very bright mass, and that is very typical of mucinous carcinoma. High T2 signal is associated most often with benign findings, but this should not dissuade us from biopsying a mass that looks like this.
And then most recently here we see a image of her lung metastasis. Do you want to just quickly describe the positive finding?
Sure, we do see a mass in the lung, as well as some perihilar adenopathy, both in this axial slice as well as in the coronal slice.
Okay. And again, just to reflect back on her previous definitive surgery for her early stage disease was conducted in 2013. With respect to her chemotherapy and biotherapy, she's been on Palbo and Fulvestrant. Future treatments now are yet to be determined. She had originally, or at the time of her original diagnosis, was treated with tamoxifen in the adjuvant setting, but in 2018 is the time when she received her diagnosis of metastatic disease to the lung. At that time, she was switched to Fulvestrant, and it looks as if Palbo was added at some point in her regimen. So if the patient is indeed progressing, what would be the recommended next line of treatment? And how do you select which CDK inhibitor to use in general? And do they vary in toxicity, and do you change them if toxicity develops? But first, Dr. O'Shaughnessy, I think this is predominantly a medical oncology related question. What are your thoughts about this case and recommendations?
I think she presented at 48 with her metastatic disease, if I'm interpreting that correctly. If she was diagnosed at 43 and had tamoxifen, she had a low recurrence score, and she had what appeared really to be a very favorable cancer, nodes negative, ERPR both strongly positive, low oncotype. So she appropriately did not receive chemotherapy. So it's very unusual for her to develop metastatic disease. So that's the first thing that needs to be said. Unfortunately, it's never zero, If she were 48 at the development of metastatic disease, then she would need ovarian suppression in addition to fulvestrant or a BSO, but it could well have been that she had a BSO along the way, potentially. So the choice of first line metastatic ER positive HER2 negative disease is, generally speaking, endocrine therapy. And certainly in her case, that is something that would be highly prioritized. And we do use CDK4/6 inhibitors virtually in everyone because of the very, very long prolongation of progression-free survival, at least a year improvement in progression-free survival, with median progression-free survivals over 2 years in all the first-line studies. I would wonder if does she have oligometastatic disease, that could be approached surgically and with radiotherapy. She just had some mediastinal nodes, a solitary lung lesion. Is there something we could think about in terms of cytoreduction with a combined modality approach? I think that's a good strategy, is to get the body burden of disease down as low as possible to try to keep her NED for as long as possible. With regard to endocrine therapy with a CDK4/6 inhibitor first line, there was a randomized trial called the Parsifal study, which looked at fulvestrant versus an aromatase inhibitor first line, both with a CDK4/6 inhibitor, and the results were equivalent. So I think one can go either with a fulvestrant or an aromatase inhibitor. Often we'll start with an aromatase inhibitor and a CDK4/6 inhibitor because upon progression, we would often, if she had a PIK3CA mutation, a common second line endocrine therapy would be alpelisib with fulvestrant, for example. Or if she didn't have a PIK3CA mutation, we could go with fulvestrant or exemestane with everolimus, for example. With regard to which of the CDK4/6 inhibitors to utilize first line metastatic ER positive HER2 negative, all of the randomized trials, which were basically aromatase inhibitor plus minus CDK4/6 inhibitor, they all had the same hazard ratios of around 0.55 and all had a year or more improvement in progression-free survival, and all had median progression-free survivals of over 2 years. The results really look superimposable. And so for a very endocrine therapy sensitive cancer like this, I think one could go any of the three options on CDK4/6 inhibitors would be would be absolutely fine for this patient. Abemaciclib has more in the way of GI toxicity, diarrhea, and the ribociclib and the palbociclib do not have that. So sometimes in an endocrine therapy sensitive situation like this, we will use palbo or ribo, and in patients with primary endocrine therapy resistant disease, which this patient does not have, we might consider abemaciclib because of data in the primary endocrine therapy resistant patient. And more recently, ribociclib has also shown us excellent data in the primary endocrine therapy refractory situation. But these are subset analyses. These are not big phase 3 trials. The big phase 3 trials basically show that these are all very, very effective agents.
In a different scenario, if she was on abemaciclib and had a lot of GI toxicity, you feel it's safe to switch over to a different CDK4 inhibitor?
Yes, you definitely could. Generally with abemaciclib, the diarrhea, tachyphylaxis after 4 to 6 weeks, it's also very diet dependent. Patients who eat a healthy salad, a big healthy salad, fiber will have more diarrhea, or heavy, spicy, fatty foods will. So it's very diet dependent. The women very quickly figure out what they can eat. And then once they get beyond 4 to 6 weeks with some loperamide, usually people are down to a couple loose stools a week. But I have had patients who have had significant grade 3 diarrhea. Dose reduction certainly does help. I haven't had to switch anybody off of it, but I think it would be fine if you had a patient who was intolerant of abemaciclib to switch to palbociclib or ribociclib.
And if this person is on fulvestrant and palbo and progresses, what would be your next thought of next line of treatment?
The next thing you really need to know, and germline BRCA has already been ascertained, and she's negative. So that's important because we have PARP inhibitors that we want to consider for therapy as well. But the next thing we need to know biomarker-wise is the PIK3CA mutation status. And that can be evaluated either on her primary breast cancer or on her metastatic biopsy or on circulating tumor DNA. And any of them would be fine because we think by and large, PIK3CA mutations are truncal mutations. They occur early in the development of breast cancer. But having said that, there have been some series that have shown that perhaps 10% of patients will be found to have circulating tumor DNA that has a PIK3CA mutation, and you couldn't find it on a primary biopsy or a metastatic biopsy. So there may be about 10% that it's either acquired or was just simply missed on tissue analysis. So a lot of us will get CT DNA, and if a PIK3CA mutation is found, then you could definitely offer alpelisib. Just recently at San Antonio, however, from the SOLAR-1 trial, they showed that in patients who didn't have ctDNA positive for PIK3CA, that it was not uncommon that one could find it in a tissue analysis. So it turns out if you start with ctDNA, it's negative for PIK3CA, you definitely want to go back to tissue and do next generation sequencing for the PI3 kinase mutation, or you can do focused PCR-based analysis for PIK3CA as well. But it's very, very important that we know the PIK3CA mutation status.
Thank you. And Dr. Shaw, do you have any comments with respect to management of oligometastases with consolidative local treatments?
Yeah, oligometastatic disease is probably the biggest buzzword in radiation oncology clinical trials right now, and really it kind of breaks up into 3 groups: synchronous oligometastatic disease at the time of diagnosis, metachronous, developing a 1 to 3 sites somewhere down the road, and then oligoprogression, being on systemic therapy and having just a few sites or 1 site that progress. In this patient, if we were to consider that, I would actually have a pretty good look at the mediastinal lymph nodes to make sure we truly think those are involved. And if there was any concern, I would actually do an EBIS to confirm that those lymph nodes were involved. If it was lung-only disease and those were negative, I would consider something like 1 to 5 fractions of SBRT just to that lung nodule. If the lymph nodes were felt to be involved, it becomes more challenging because regimens like SBRT, including 10 gray times 3, which is being used in multiple clinical trials, isn't really appropriate. So we would then consider a slightly different regimen if we wanted to consolidate the oligometastatic disease, something like 45 to 60 gray and 15 fractions to be safe in terms of normal tissue toxicity.
Great. And SBRT is stereotactic body radiation therapy.
Yes, thank you, Dr. Buckles, absolutely.
Thank you. Interesting case. Thank you to the panelists for their comments.